SSCY seminar series for 2021. So welcome everyone, and thank you so much for attending. To begin, we would like to acknowledge that we are on Turtle Island and that this is Treaty 1 land, and it's the traditional territory of Dakota, Anishinaabe, Cree, Oji-Cree, and Dene peoples, and the homeland of the Métis Nation. So today I am pleased to present Dr. Christy Pylypjuk, and the topic of her presentation today is life after preterm pre-labor rupture of membranes at previability. Dr. Pylypjuk is an assistant professor at the University of Manitoba in the Department of Obstetrics, Gynecology, and Reproductive Sciences. She is a subspecialist in maternal fetal medicine with an expertise in fetal ultrasound and high-risk pregnancy, and a recently appointed clinician scientist in the department. She is the assistant director of the Provincial Obstetrical Outreach Program and the assistant program director of the Maternal Fetal Medicine Fellowship Training Program at the U of M, the HSC site lead for the Canadian Preterm Birth Network, scientific member of the Children's Hospital Research Institute of Manitoba, and past medical director of the Provincial RH Program. Her research interests relate to quality improvement of prenatal diagnosis using fetal ultrasound and prediction of adverse pregnancy and long-term health outcomes. So I would just a couple of housekeeping items before I turn this presentation over to Dr. Pylypjuk. I see that everyone's video is off. This session will be recorded, just the presentation portion. So for those of you that would like to ask questions by unmuting at the end, that part will not be recorded and posted on the SSCY website. So I invite you to do that. I will also moderate the chat box. So if you prefer to add questions to the chat box, we will have time for questions at the end. So thank you very much, Dr. Pylypjuk, and I will turn this presentation over to you.
Wonderful. Thank you, Liz, and hello to everyone in the SSCY family. Thank you for the kind introduction and for the opportunity to speak to you today. I have to say, for anyone who's involved with organizing rounds and getting speakers for any types of presentations, Liz had a very easy sell when last spring we first met in her new role at SSCY, when she requested whether I'd be interested in talking about some of the joint research that I was working on, when she told me that this was breakfast rounds and that you in fact had breakfast at SSCY. It was a no-brainer, and I was a shoo-in for a presentation, but here we are. As COVID would have it, I'm ringing in 2021 with breakfast at SSCY without the breakfast. So hopefully in the not too distant future, I'll have a chance to come back and we'll be able to meet in person and discuss some of this exciting work. The work I'm presenting today would not be possible with my collaborators. So I need to acknowledge Dr. LaDonna Majot, who was a resident when she undertook some of this work, is now a staff obstetrician at Boundary Trails Hospital in Winkler, Dr. Kat Nickel, who is currently a maternal fetal medicine fellow here at the University of Manitoba from Saskatoon, and all of you on the call will know Dr. Valencia Ricci, who's a developmental pediatrician at SSCY. I don't have any conflicts of interest to disclose prior to my presentation, but I would like to acknowledge that I have received grant funding from the Manitoba Medical Services Foundation and the Children's Hospital Research Institute of Manitoba as part of a new investigator grant, although not related to this work. And I have received funding from the SOGC as a speaker at some of their conferences. As Liz mentioned, it's impossible not to proceed and acknowledge that all the work that I do and that we do for those that are based in Winnipeg, whether that be research or clinical work, is again located on Treaty 1 lands, that we acknowledge the harms that have happened in the past and that we endeavor to work forward together, correcting those and in a spirit of reconciliation. So my hope for today's presentation is that by the end of the session, everyone is familiar and understands some of the pathophysiology and morbidity associated with little pPPROM in pregnancy. That some of this information that we've gleaned about local outcomes could actually help us improve firsthand counseling of families who are experiencing a complication of pPROM in pregnancy, and discuss some of the outcomes associated with birth after pPROM. And ultimately, the goal would be to enhance general knowledge about some of the neurodevelopmental outcomes, some of our preliminary findings, and acknowledge all the work that is still ahead of us. But hopefully in collaboration with SSCY, these are things that are achievable in the future. By way of background, it's important for us to sort of understand, what does typical or routine prenatal care look like in Manitoba and across Canada? So this is sort of a pyramid that goes through some of the intervals with which pregnant patients are seen in Manitoba. In the first trimester and extending up to 28 weeks, patients are seen every 4 weeks by their maternity care provider. From 30 to 36 weeks, patients are seen every 2 weeks. And in the last month of pregnancy, patients are seen weekly. Now, this is a bit of a historical paradigm of prenatal care, relating to the fact that most adverse outcomes in pregnancy tend to occur later in pregnancy. The thought being that if we increase surveillance later in pregnancy, we should be able to intervene and detect these risks clinically. Be that maternal high blood pressure, which tends to occur later in pregnancy, fetal growth restriction, and stillbirth is the penultimate thing that we are trying to prevent. As part of this scheme of prenatal care, we are recommended to do first trimester dating ultrasounds on all patients, coinciding with that first prenatal visit less than 12 weeks or less than 3 months of pregnancy, knowing that many women, many individuals that are pregnant may not actually know that they are pregnant at this time. Due to some of the resource limitations in our province specifically, first trimester scanning is not standardly done, although it is recommended, and we are working forward to that. Most pregnant women have a barrage of early prenatal blood work, confirming blood type, checking baseline serology and immunity to common infections that could cause adverse complications in pregnancy at that first visit. And then people don't have follow-up again until about 15 to 20 weeks, at which time that corresponds with maternal serum screening testing that's offered to all pregnant women in Manitoba. This is a maternal blood test that screens for common genetic aneuploidies, such as Down syndrome or trisomy 21, trisomy 18, and also looks at alpha fetoprotein levels in an effort to detect structural defects in the fetus, such as spina bifida or other body wall abnormalities. We have been doing MSS screening in Manitoba since the late 80s. We have one of the largest second trimester screening programs in the world. And the uptake of maternal serum screening in Manitoba is about 85%. And it's after patients are starting to get these results back that they are due and standardly scheduled for a 20-week ultrasound. Now, this is typically done in general radiology departments around the province. The intent of that scan is to look for structural abnormalities in the baby, early fetal growth disturbances, and correlate the findings of ultrasound and the maternal serum screening results. And that's done again in standardized units throughout the province. Corresponding with increased surveillance in the latter third of pregnancy, around 28 weeks, we also perform a standard gestational diabetes screening test on all pregnant moms in Manitoba. Prevalence of gestational diabetes is around 5 to 7%, and we know that sometimes in pregnancy, we're actually unmasking women who have undiagnosed pre-existing type 2 diabetes, which itself incurs higher risk. So who do we actually see in maternal fetal medicine if routine prenatal care looks like that? Most women only have a 20-week ultrasound. And we can't get too far without talking about some of the real pioneers and champions of maternal fetal medicine that originated in Winnipeg and have since migrated elsewhere. But we were sort of the home of the fetal transfusion and some of the pioneering work. Bruce Chan was not an MFM, but someone who was working towards development of ROGAM. So we were one of the first sites in the world to do intrauterine transfusion for fetuses detected to have fetal anemia, whereby you perform an amniocentesis and you very carefully place the needle inside the umbilical cord and provide a fetal transfusion of adult blood in cases of fetal anemia. Frank Manning is well known around the world for his pioneering work in using ultrasound to try and predict adverse perinatal outcomes and really perinatal morbidity, trying to predict the risk of some of those late pregnancy complications associated with stillbirth and often associated with fetal growth restriction. He developed something called the biophysical profile, which is still in use around the world and certainly at our centers today, that are trying to detect based on fetal behavior that we can watch on ultrasound, amniotic fluid volume, and some other measurements. What is the chance that the baby is actually hypoxic or acidotic in the womb? What is the chance that they are at risk of morbidity or mortality? What is our indication for preempting early delivery? So that work and the original research was done here as well. Nowadays, we have two sister fetal assessment units between the New Women's Hospital and St. Boniface Hospital, and we average upwards of 10,000 scans per year of people who need to have ultrasounds in pregnancy due to other complications above and beyond that routine prenatal care. You don't get very far in maternal fetal medicine without it really getting ingrained in you during your training how to think about how certain medical conditions influence pregnancy and vice versa. So essentially, we are always asking ourselves, what is the effect of condition X on pregnancy for mom and for the baby? And also, what is the risk of pregnancy on the other condition? So taking diabetes, which is very common in Manitoba, we know that by itself, gestational diabetes, pre-existing diabetes have an effect on pregnancy. It is associated with an increased risk of developing high blood pressure of pregnancy. It can cause fetal growth disturbances that itself relate to intrapartum or birth, delivery complications, delivery trauma in the fetus, and does need to be watched closely. It also carries itself an increased risk of iatrogenic or indicated preterm birth if the condition is not controlled. But on the flip side, diabetes itself, or pregnancy itself, pardon me, has an effect on diabetes. We know that many of the hormones naturally produced by the placenta to enable free sugars available for the developing fetus, which are adaptive and a normal part of pregnancy, can actually cause increased sugars in moms with pre-existing diabetes that could then be dangerous or lead to dangerous levels of hyperglycemia, both for mom with related morbidity, but also to the fetus. This can cause massive acceleration in growth where babies essentially become compromised with the amount of blood flow that they're able to get from the placenta, which can cause an increased risk of stillbirth. Uncontrolled maternal sugars are related to the increased risk of fetal anomalies, such as heart defects and spinal cord abnormalities, and long-term health sequelae associated with this condition. So we're always thinking about this cycle and remembering that in pregnancy, we have two patients that we're thinking about. Conversely, some other common medical conditions that are seen in young reproductive age women are autoimmune conditions such as multiple sclerosis, lupus, rheumatoid arthritis. And in those conditions, pregnancy tends to have the opposite effect, whereby as long as the condition was decently well controlled prior to pregnancy, no flares up and around the time of conception, we know that pregnancy actually reduces the risk of flare and often decreases the symptoms of those conditions. Independently, many of those conditions can still have effect on the placenta. Many of the medications that moms are on outside of pregnancy are not safe in pregnancy and can have a detrimental effect of the fetus. So this is kind of the play that we're always thinking about in maternal fetal medicine when we think about how we're providing the best possible care, how we're trying to prevent complications and reduce morbidity in the highest risk pregnancy. And that's the lens that I bring to my research, knowing that most moms don't ever need our care and don't ever need to see us. The folks who do see us standardly, they generally break out into three groups. Those where fetal complications have been diagnosed in the current pregnancy, again, thinking back to either the maternal serum screen that has flagged as an increased risk or structural anomalies or growth disturbances that are already predicted at the 20-week ultrasound. We would also routinely see women with past obstetrical history of complications, and usually those are related to placentally mediated complications of pregnancy, preterm birth, stillbirth, hypertensive disorders of pregnancy such as preeclampsia, and fetal growth restriction. And then we have the group of women who enter pregnancy with pre-existing medical conditions or develop complications of pregnancy, most commonly gestational diabetes or gestational hypertension. These women, because of risks to both themselves and the fetus, warrant increased surveillance, and they would be seen in fetal assessment for multiple follow-up scans, as many as 2, upwards of 10, depending on the condition and the individual control. So the importance of fetal assessment and focusing on fetal ultrasound, which is our happy place clinically as MFM subspecialists, is really ideally trying to prevent complications and ultimately improve outcomes. So for the group of patients that are here in the first column that are referred because of a current concern with the fetus of this pregnancy, the importance of fetal assessment is really accuracy of diagnosis, trying to refine our prediction models and our ultrasound signs, which can be difficult when we're looking at a human who's inside another human, but accuracy of diagnosis to the best of our ability to help stratify the immediate perinatal care that this baby would need, to help counsel families, is this something that is correctable after birth or not? Are there a constellation of symptoms that we're seeing, or features, pardon me, that would suggest there might be a genetic cause. That's particularly important in settings where we're considering invasive testing, which itself carries a risk. So commonly we think of amniocentesis, which we have an association of about a 1 in 500 to 1 in 800 risk of pregnancy loss by doing an invasive test to determine a genetic condition. Knowing the geography of Manitoba, and for everyone at SSCY, you face this as well on a daily basis. Our families don't live down the road from us, and we have a very large catchment area, including rural, northern, and out of province regions. And so a decision to displace a family and recommend delivery in a tertiary center, while sometimes indicated, is sometimes not without risk and due consideration. So what we're seeing fetally would help us plan the delivery, as well as the immediate postnatal multidisciplinary care. Who needs to attend the birth? Besides the person doing the delivery or providing the maternity care, who from neonatology will attend? Which surgical teams need to be aware of the case, and depending on the nature of the condition, the actual timing, the really finesse timing of postnatal surgical repair, knowing that labor is sometimes a very tricky thing to predict. We also talk with families at length during the pregnancy, but afterwards as well. What's the recurrence risk in a future pregnancy? Is this something that warrants consideration? Is this a random occurrence? What will care be like moving forward should they wish to expand their family? When we think about prevention strategy, this applies to the group of patients whom had an adverse obstetrical outcome in the past. We know that aspirin, when given between 4 months of pregnancy until the month before the due date, can improve placentation, improve placental blood flow, and reduce most of the placentally mediated complications of pregnancy. The other common example is for patients who've had a history of preterm birth. We have one of the highest rates of preterm birth in the country, depending on the cause. But when we think about spontaneous preterm birth, there may be a role for cerclage or vaginal progesterone. So the picture here is a cross section of the uterus. This is the cervix, which should be closed. And we can see the baby's head here and the bag of membranes prolapsing through the cervix. Here is that bag of membranes pushed back in, the cervix closed, and you can see the 2 white dots pointing to the Merceline tape cerclage that's been placed to reduce the risk of premature rupture of membranes and early delivery. These patients are watched closely with interval or serial cervical length surveillance. And again, our goal is to intervene before there's a complication. And if we can, to try and mitigate the risk of severe morbidity by optimizing the conditions of early birth. And in the last group, women who have pre-existing medical conditions of pregnancy, again, we know that we want to optimize their health preconceptionally ideally, but around the time of conception in that early period of embryogenesis in the first 8 weeks of pregnancy. We want to ensure that these moms are on pregnancy-safe medications, that some may need to be on aspirin if they have pre-existing medical, certainly vascular type conditions, including diabetes, that would put them at risk of having poor placental implantation, poor placenta function. If we think of the placenta as a nest of blood vessels, aspirin can be helpful in those women. And increased surveillance. This is a picture of uterine artery Dopplers, where we can actually measure and look for early signs of increased placental resistance to blood flow that would predict placentally mediated complications in pregnancy. If we see increased resistance to blood flow early in pregnancy, these women are followed in fetal assessment. And we also think about timing of delivery, trying to get it right, trying to minimize the intrauterine risks, which sometimes indicates early delivery, but at the same time, not in suggesting delivery when it's too soon, when the risk potentially of prematurity are higher than the risk of the underlying complication. So these are the patients who we see in fetal assessment. It is a small portion of the obstetrical population, but I'm sure you can appreciate this is a group that does need to be followed closely. Now, preterm birth is one of the most common things, as I had mentioned. One of the highest rates in Manitoba, or in Canada, pardon me, is here. And for spontaneous preterm birth, we know that if someone has a history of cervical incompetence, where the cervix dilates without warning, without contractions, putting a stitch in, or a pessary, which is new on the market, can reduce the risk of spontaneous preterm birth. Or vaginal progesterone can also reduce the risk of preterm birth. But there's probably more to the story. We know that preterm birth is multifactorial in the reasons as to why it happens. And a lot of our understanding about outcomes, risk factors, comes from work across Canada through the Neonatal Network. The Preterm Birth Network is looking at ways to improve outcomes at very early viability, things that can be done easily at the bedside at the time of delivery, if the preventative measures fail and you are facing an early preterm birth. And the 4 goals of the committee are to really optimize timing and administration of antenatal corticosteroids, as well as magnesium sulfate for very preterm babies to improve neuroprotection. We know that delayed cord clamping, allowing passive perfusion of blood from the placenta, can decrease mortality up to 30% in babies that are born preterm. We know that hypothermia in babies that are certainly preterm can be very detrimental to short and long-term outcomes. So to try and maintain temperature, having warm towels, having plastic bag devices at the bedside is an easy mitigation strategy for early preterm birth. And there's some emerging evidence about the actual positioning of the baby to avoid lateral head or neck flexion. And preventing venous congestion, the brain can actually reduce brain bleeds in this population. So we try our prevention strategies, but if still faced with a preterm birth, there are other things we can do to try and improve outcomes in this population. How do we counsel families who we are seeing in fetal assessment, or we are seeing in our obstetrical triage, or on the labor floor in active labor, about what the outcomes are? And really, most of what we know comes from the Canadian Neonatal Network, and recently the addition of the Canadian Preterm Birth Network arm, really to look at improving outcomes amongst preterm birth infants. So the Preterm Birth Network is the maternal fetal medicine and obstetrical side of early perinatal care, looking specifically at outcomes of our most earliest babies, so under 29 weeks. And we piggybacked off the very excellent work of the Canadian Neonatal Network, which, as everyone knows, is a conglomeration of all tertiary level NICUs across the country, where on a quarterly basis, they abstract information about newborns admitted to their unit and try to develop trends and actively pursue quality improvement strategies through their EPIC processes to improve outcomes in these babies. The other branch of the Canadian Neonatal Network, which is known well by the team at SSCY, is the Canadian Neonatal Follow-Up Network, which has been led by Diane Modeman. I know that Florencia Ricci and Cecilia DeCabo are also involved in the neonatal follow-up clinic. But once we have a neonatal admission, Once a baby is there, once we've sorted out, were there preventable risk factors? What type of care did they receive? Once those babies have graduated and are leaving the NICU, what does their long-term follow-up look like? And that's been a huge contribution from the Canadian Neonatal Follow-Up Network. There's also a parent network that's been very active as part of this. In this past year, they held their first quality improvement initiative, which was parent-led, to try and evaluate what are the priorities of parents. All the branches of the Canadian Neonatal Network have a parent member on their committees, help guiding the research and the investigation into questions that are meaningful to families. From the most recent Canadian neonatal data, you can see here the trends in birth across the country. We also have survival to discharge data, and you can see that there's a marked improvement, a huge jump in survival of babies born 24 weeks and beyond, another jump at 26 weeks, and really beyond 28, 29 weeks, we're approaching as close as we ever get in medicine to 100% as far as survival. So a lot of our counseling comes from these numbers and new obstetrical guidelines that address how are we counseling families really at the earliest of viability, so borderline viability. We know that represents a very small fraction of babies that we deliver, less than 5% of births. And again, the survival increases exponentially with almost each passing week. Once we're past 25, 26 weeks, survival is 80%. Survival only tells us half the story, though. It tells us who has survived to discharge from hospital. Sometimes we have a sense of what are some other complications of prematurity. But what is very hard for us counseling families on the obstetrical side is really what happens once they leave hospital. We get very good at counseling, as we talked about. What are the risks of pregnancy to the underlying condition? What's the risk of the underlying condition to the pregnancy for mom and the baby? We are good at anticipating what might happen in delivery in a certain complication. I think pediatrics, you do it the best with anticipatory guidance, but I would say MFM is a similar a specialty in that regard, trying to preempt potential complications when we speak with patients, when we speak with their primary care providers, when we speak with other specialists. But we're less good at counseling in the long term, and that was part of the interest in some of the research that I've collaborated with Florencia. The Canadian Neonatal Network has also been helpful in trying to elicit risk factors as to why preterm birth or early pregnancy complications actually occur. We know that all of these things are risk factors for spontaneous preterm birth. The extremes of maternal age, so advanced maternal age, as well as very young patients, smoking and substance abuse, infections, and prior histories of surgeries on the cervix, a prior late miscarriage or preterm birth, and anything that overdistends the uterus, such as multiple pregnancies, make up the bulk of patients that we see in our neonatal networks and subsequently in our neonatal follow-up networks. When we think about the centuries that women have been having babies, when we think of the actual role in the initiation of labor, we know that the fetus actually plays a huge role, whereby we have an increase in fetal ACTH that leads to an increase in fetal cortisol. And it's cortisol that actually inhibits progesterone and thus promotes contractions. Once we sort of have the cortisol inhibition. We know that from the posterior pituitary, we're simultaneously getting oxytocin secretion. The oxytocin stimulates smooth muscle. And so either by head compression of the fetus to start, pressure against the cervix that leads to mechanoreceptor signaling in the brain that then further increases oxytocin, or whether the pressure from the fetal head comes after the oxytocin. It's a little bit of the chicken or the egg, but that's sort of the processes of labor at a cell signaling level. When we think it more at the cell membrane level, we know that there's a process of inflammation at the deciduant, at the level of the amnion and the chorion, or at the level of that interface of the bag of waters and the myometrium, that through the course of labor leads to an increase in release of cytokines that ultimately increases the production of prostaglandins and uterotonins, and that is leading to contractions. From the contractions from the uterotonins, we actually get an increase in metalloproteases that lead to apoptosis, and that leads to cervical change and rupture of membranes. That's the normal course of labor. Usually there's labor. Through the course of labor, we have rupture of membranes. But that's not always the case. For about 1 in 10 women, their first sign of labor is breaking their waters, which happens without contractions and without any cervical change. And it's really in that group where we're trying to see, are there differences in outcomes? Why does it happen? And what's the significance of a dry labor or a labor where there's low amniotic fluid? So this is where we're meeting the PROMs. For any of the medical students or residents who are on the call, this takes a lot of mental gymnastics when you are learning different things. How many P's in PROM? So for those who don't know that I grew up on a farm about an hour south of Winnipeg, you will know that I do not shy away from any opportunity to have animal figures in my slides. So I thought this was a good depiction of the PROMs that I'll be talking about today. The most common is term PROM. So this is pre-labor, without signs of labor, rupture of membranes. So this is the 1 in 10 women who have no signs of labor, no contractions, and by some mechanism, apoptosis, they experience a break in the amniotic fluid membrane and experience a gush of water and present to hospital. pPROM occurs before term PROM. So this is in the preterm population. If you experience pre-labor rupture of membranes, you're considered pPROM, and that happens in about 3 in 100 patients. What's important to note is the natural history. So for 9 out of 10 women, the first sign of labor are the usual things: contractions, cervical change, pelvic pressure, that then at some point leads to rupture of membranes. But for the 1 in 10 patients at term who experience rupture of membranes, what we would expect is that 90% of them in the next 24 hours will go into labor spontaneous by some mechanism of increased head compression that is again activating the mechanoreceptors in the brain that leads to oxytocin production or other mechanisms. What's important to note is that the farther away you are from your due date, the farther away you are from term, the longer that latency is from the time you break your waters until the onset of labor. And that process is quite variable. For pPROM, that process can be days and it can be weeks, which is how we get in a situation where we have pPROM that occurs actually prior to viability. We now define viability as 23 weeks of gestation. And so little pPROM refers to women who experience a rupture of membranes prior to viability, remote from their due date, and may actually remain pregnant for many days or weeks without any intervention because of this sort of this lag in latency between timing of rupture of membranes and due date. That is very rare. So it occurs in about 1 in 1,000 pregnancy. It's not something we see commonly, but historically has really been regarded as a universally terrible and lethal condition of pregnancy. And many patients did not continue pregnancy with some of that counseling. Why do we care about PROM at any point, any of the PROMs? Well, the immediate risk when you have a puncture, an opening in the bag of waters, is that, especially early in pregnancy, a very small fetus doesn't sort of plug up that hole or that space where the bag of waters has opened. And it's actually a risk of the cord or the umbilical cord prolapsing through that opening into the cervix, which is one of our few obstetrical emergencies, and that mandates immediate delivery because some cord compression could lead to fetal demise or severe asphyxia. With low fluid that can result after breaking your waters, there is inherent risk of cord compression through the natural movements of the fetus in the womb. And the acute change in pressure that occurs when you have a break in water causes a shearing force of the placenta, and can cause the placenta to peel off prematurely, which is called a placental abruption. It can result in acute hemorrhage for mom, which could be life-threatening. It can result in fetal compromise, fetal heart rate decelerations, poor growth, and again, it is an obstetrical emergency that can happen immediately upon early breakage of water without the signs of labor. There are also later risks. So we think about dry labor. Again, this happens when we add contractions to low amniotic fluid, and it really increases the risk of cord compression. We also know that there are risks to the fetus in being in an environment that does not have an adequate amount of amniotic fluid, where they have an increased risk of contractures from the malpositioning, the inability to stretch and move in a normal way that a baby that has a normal amniotic fluid volume around them. There's a very high cesarean section rate associated with these pregnancies by really all of the combination of factors, be that cord prolapse, cord compression, some compromise to the integrity of the placental blood flow, if there's underlying infection, and if there's chorioamnionitis diagnosed, we diagnose with fever and some specific findings. But both intrapartum and postpartum fever have significant morbidity for moms, significant morbidity and mortality for newborns, particularly those born preterm. And we know there's a significant association with intrauterine infection and the risk of cerebral palsy postnatally. PROM will increase the potential for antibiotic exposure before and during and after labor. We know that antibiotic stewardship is really at front of mind for almost all disciplines, knowing that exposure to antibiotics does significantly impact the natural microbiome of these babies. We try to be very restrictive and judicious with what antibiotics we use for moms in labor, knowing that it has an effect on the fetus, but many times it's indicated in this population because the risk of an ascending infection is so high, again, when you've had a breach or a break in the bag of amniotic fluid. Now, what's specific for rupture of membranes that happens at previability is that if the fetus is exposed to a low amniotic fluid or a no amniotic fluid volume at the time of critical lung development prior to 20 weeks, it can result in significant pulmonary hypoplasia. That even if the lungs grow, even if the baby grows normally, does not have to be delivered for infection reasons or a compromise in the placenta, it may occur that a live-born baby may not have lungs that are ventilatable because there was no fluid at the point of critical lung development less than 20 weeks. And this is a particular concern, again, of little p, pPROM, in addition to the sepsis and all the other complications of prematurity that everyone here is very familiar with. PROM results in long NICU stays, that's even when it occurs at term, and overall a high perinatal morbidity, including the risk of cerebral palsy in this group. Because of the concerns related to pPROM, there's actually been several clinical trials that have looked at, can we fix this? Is there something we can do? So there are some clinical trials that have looked at just infusing, sterile saline to try and artificially create an amniotic fluid filled environment to reduce cord compression and other complications. But again, if you have an opening in the membrane, that fluid just leaks out. And there are risks of repeatedly instrumenting the uterus, including introducing infection inadvertently, including inadvertently causing an abruption because of expansion and contraction of the uterus. There's risk of alloimmunization and other things as well. There was also a few trials that looked at membrane sealants, whereby you would actually infuse certain different fiber-related products that would swirl around the amniotic fluid and almost liken to, a dish sink with dirty water, where everything would sort of intentionally kind of swirl towards the drain. But as probably happens as at your home as it does at mine, many times the little particles actually just got stuck around the edge of the membrane and didn't find their way to actually patch or seal the amniotic sac. So these trials were stopped prior to completion because there was no significant improvement in outcome. So at the moment, we don't have a way to correct premature rupture of membranes that happens without labor, it is a waiting game. It is expectant management. So part of our goal was in Manitoba to look at what were our outcomes over about from 2009 to 2015 with regards to pre-viable pPROM. How many cases do we see, knowing that it's about a 1 in 1,000 occurrence? What were the outcomes? Because anecdotally, we had started observing that there were differences between sites in terms of how patients were being counseled on some of the outcomes. And so we ended up having about 161 cases identified from health records during that time period at both St. Boniface and Health Sciences Center. Ultimately, some were miscoded, and the gestational age actually occurred after 24 weeks. So a reminder that 2015 is when we changed our definition of viability to 23 weeks. So for this study, we did include up to 24 weeks. We had 113 cases that met the inclusion criteria, a few more at HSC than St. Boniface. And based on that initial counseling, we had about 1 in 5 that opted for a termination of pregnancy after hearing about the potential risks of pulmonary hypoplasia, the potential for long-term risks in association with intrauterine infection and cerebral palsy, chose not to continue the pregnancy. What was interesting to us is there was a significant difference between sites and seemed to correlate with which hospitals had access to services related to termination of pregnancy. But the vast majority of patients actually opted for conservative management. In the end of those, we excluded a few because the latency was less than 24 hours. And with a historical chart review, it's very hard to know when we think back to kind of the pathophysiology of the onset of labor, did the rupture of membranes happen as part of that process? Were there already some early cervical changes? And so it's custom in looking at sort of pPROM studies to exclude a latency from rupture of membranes to delivery that's under 24 hours, because you presume the cases like the more common, where at some point there was an onset of labor and the rupture of membranes occurred secondarily to that. We know that from the patients that opted for conservative management, only about a third of those were still viable at delivery. There was a significant number of babies that were stillborn or had severe growth restriction or other signs of placental compromise, again, related to abruption and cord compression that resulted in a stillbirth. And of the babies that were alive until delivery, about 1 in 4 survived to hospital discharge. Now, these numbers are small, and 20 survivors from 113 doesn't sound like a large number, but this number was much higher than what we were expecting. And our secondary interest was to look at, were there any predictors of who would end up in this of these 19 infants? Were there ways we could better refine counseling for families and help sort of preempt what the natural course of a pregnancy complicated by pre-viable, so rupture of membranes prior to 24 weeks. Again, this is a tabular form of some of those outcomes. So those that had IUFD or stillbirth before labor, and those that had interpartum. We know that the average gestational age was around 25 to 26 weeks. Recalling the data from CNN, we know that we're getting to around 80% survival in this group. Again, not stratified by pPROM, but for preterm birth of that gestational age. And again, we had not surprisingly, high rates of respiratory morbidity, as we would expect. About 50% of babies had RDS. Only 1 in 4 that had the bronchopulmonary dysplasia, which is what we worried about primarily with pPROM that occurs at previability. 20% of babies had infections. Same number had limb contractures. Only 1 case of IVH that was noted, and again, the mortality that we described before. When we think of the median age of delivery between those that survived and didn't survive, there was actually no difference between that group. There was no difference either between latency and survival. Cervical incompetence wasn't different. There was a slight difference between having bleeding prior to rupture of membranes. Most likely, we know that bleeding is associated with some increased exposure to metalloproteases against the bag of waters that could cause weakening and cause spontaneous rupture of membranes. that was slightly higher in the surviving group. And really the main drivers was kind of the gestational age at delivery, and the latency period was all related to how old you were when you were born. So when we looked at amniotic fluid volumes, there was no correlation. There was a significantly higher birth weight, but that was controlled for by the fact that these babies had a greater latency and delivered at a later gestational age. When we looked at complications between those that opted for conservative management and termination of pregnancy, not surprisingly, those patients that were pregnant longer experienced more abruptions, mainly because of that prolonged exposure to the low amniotic fluid cavity. There's also increased risk of infection and some differences there. So we were sort of surprised by these numbers that while there were a high rate of complications, this is a rocky road for families to experience little pPPROM. It wasn't uniformly lethal. 1 in 4 babies whose families chose expectant management survived to hospital discharge. And again, we were interested in fetal assessment. Were there more refined predictors of who would survive? But we found that really gestational age was the thing that drove it. The gestational age at when you broke your waters and when you delivered was the strongest predictor of survival. And again, we didn't find anything obvious with amniotic fluid volume. But what happened beyond then? So we were happy that we were able to kind of give some refined counseling and numbers of our families who had pPROM and what their course might be like until they left hospital, if they were 1 in 4 that were able to. But what about beyond that? And this is where we sort of enter the team from SSCY and some collaborative efforts with Florencia and the existing database at the neonatal follow-up clinic that could help us answer the question. So Kat Nickel, who's our current MFM fellow from Saskatchewan, again, we sort of distilled down the 113. We ended up actually having a few other children who did not survive until their 18 months to 24-month corrected age visit. And so we were left with only 7 children that ended up being seen in the neonatal follow-up clinic at SSCY compared to the 113 in the original cohort and the 90 in the expectant management group. So it was a bit smaller than we were hoping for. It appears that maybe some of the children had followed up at St. Boniface, but the most actually did not present for follow-up care afterwards. What did we find in these 7? We were still curious to look, even though we had distilled it down to only a small number. And our goal was to look at cerebral palsy rates, knowing that, as we mentioned before, an increased risk of intrauterine infection can increase the risk of cerebral palsy, as can premature birth on its own. And we wanted to link these cases to their developmental outcome scores, so either developmental quotient or Bayley scores. So what we found is that in the survivors of pPROM, those that survived to 18 to 24 months, we looked at cognitive, motor, and language development, all were below the corrected age at population mean. So cognitive and motor, the mean Bayley scores were 89.7 and just over 80. For language, we saw a surprising drop where all but 1 child had a score less than, or more, pardon me, more than 2 standard deviations below the expected population mean. We really wanted to look at the role of amniotic fluid volume and whether that had played a role in these outcomes, but we were obviously, as you can see, underpowered to make a comment about that. But to our knowledge, this is sort of one of the first studies that have looked at the early developmental outcomes of pre-viable pPROM and the specific components of the Bayley score, which points that perhaps language is more significantly impaired for fetuses exposed to a low amniotic fluid intrauterine environment. To our surprise, of the 7 cases, there were no cases of cerebral palsy, and the ongoing follow-up is happening. What we don't know is how much of an increased risk does pPROM or pre-viable pPROM confer above and beyond preterm birth alone. And so we're moving forward with finding spontaneous preterm birth controls, and try to account for some of the other exposures that everyone on the call knows influence development. So exposure to antenatal corticosteroids, exposure to magnesium sulfate, socioeconomic status, and other things that are known to be quite important. But in terms of us in maternity care, being at the bedside, counseling these patients, this is starting to move towards getting a little bit more granular detail of what outcomes look like, albeit preliminary and small data, and more work needs to be done. So to conclude, as we wrap up the hour here, I'm hoping that everyone can appreciate that while pPROM is very rare, it is a serious complication of pregnancy and confers risk for both moms and babies. In Manitoba, for families that choose expectant management, 1 in 4 babies survive to discharge from hospital. 1 in 5 only will survive to their second birthday. Some very preliminary evidence linking our data set from Women's Hospital to that at the neonatal follow-up clinic at SSCY show maybe a trend towards some unique developmental effects of pPROM, particularly with regards to language development that needs further exploration, and our work is ongoing. And like I said, the next step is to find better match controls and try and increase the sample size here, as well as looking at some national collaborations. I'm hoping that at the end of this talk and moving forward, that this has sort of planted the seeds of collaboration between us, we say up the cord, so before babies are born, to those who are looking after these newborns long after we've cut and clamped the cord at the bedside and handed the baby off to you, where we can start thinking about, are there opportunities for early prevention and intervention strategies based on antenatal predictors that we are seeing well before delivery. And so I'll end there and open it up for questions, and hoping everyone